I'm Dan Dent from UT Health San Antonio, and the chair of the GME committee here for the organization, and put this talk on with the idea of thinking about diversity. And it seems to me there are two kinds of talks on diversity. There are the talks where you need mostly the white men in the room so they can hear how important it is because everybody else knows it. And then there are the talks like this, where people that maybe aren't white men can be inspired, and those of us who are can learn how to help inspire and how to help support those who look different or have slightly different backgrounds that might want to pursue a career in surgery. And so to that end, I'll go ahead and mention the 4 speakers we selected for today. And I'll let you know our first speaker, Dr. Sharmila Disanayake, is here on Zoom. Hopefully you can see her. Yes, we see her on the big screen. She's the chair of surgery at Texas Tech in Lubbock. We also have Dr. Mike Cornet, who's in private practice in San Antonio, but also spent some time on our faculty and working with Dr. Mangrum out in Phoenix. We have Dr. Laura Moore, who's a trauma surgeon at UT Houston, and Dr. Alicia Mangrum, who is well known to the members of this society, is in practice at John C. Lincoln Hospital in Phoenix and has started a residency program there. And some of her residents are here, and she's got first class of graduates was last year?
2 years ago.
2 years ago. So a very accomplished group, and we'll turn it over to Dr. Disanayake first, who will be speaking to us from Zoom. Thank you, Sharmila.
Thank you, Dan, and thank you, everyone. I really wish I was there with you. These are old friends from Southwest Surgical, and I miss the chance to be in Hawaii with you all, but such is life. So, it's a big topic, and I would say that, I hope that I'm speaking to what you all want from this topic, because it is a little difficult, right? And as Dan said, sometimes we're kind of preaching to the choir a little bit, and sometimes we're saying things that maybe need to be heard and said, and other people don't feel comfortable saying. So, it is going to be a little stream of consciousness, but I am going to ask both Dan and the other panelists, please stop me. And if I need to be more focused, ask a question and direct me, because it is a little difficult sometimes to figure out exactly where to start, right? This is the elephant. How do we take it bite by bite and tackle this? So I did my med school in Australia. Actually, I got a scholarship from when I was a high school student in Sri Lanka. And so I went to Australia and I did med school there. And recently on Twitter, a young med student had posted that she hadn't worked with a single attending female surgeon in her entire kind of med school career. And a lot of people found that surprising. And what was interesting to me, because I would find it surprising in my program, that almost certainly would not happen. I don't think it could happen statistically, where a med student was not exposed to a single woman surgeon. And so clearly it's unusual in 2021. But what was interesting to me when I looked at that is that I had to stop and think, and I'm pretty sure that there was not a single woman surgeon, and I know that there was not a single surgeon of color that I worked with as a medical student. I really do think that every single one of my attendings were white men. And what's funny to me as I thought this through and kind of this provoked, and I knew I was giving this talk, and so I was kind of mulling this over, I stopped to think whether did that ever really change my trajectory. And what was odd was it didn't. And it really literally never crossed my mind that this wasn't going to be my career and what I wanted to do. And so then I tried to dissect, why is that? Because we all have heard the saying, right? You can't be what you can't see. And we try so hard, I think, as leaders in surgery, those of us who have the opportunity, try very hard to recruit and for that diversity to become visible. And so, for example, I'm very proud that at Texas Tech, middle of nowhere, Lubbock, Texas, we have about 60-40 gender breakdown. So not quite even, but very close. But we also have about 38% minority representation. Now, they're not all underrepresented minorities. Some of these are, for example, Asian Americans who are not underrepresented, but are still a minority. And where do they fit in the intersection? I have a few African American surgeons, but not nearly enough. Where does that fit? Does it, based on the demographics of the patients I serve, which are about 8% African American and about 40 to 30% Hispanic, depending on kind of how you classified in census in my region, Should that matter? Should that be what I'm aiming for? And so this is really a difficult topic. And like I said, it's a lot to grapple with. But I also don't want to say, well, that's okay. I reached a certain number and now I'm good, right? Because I don't think that that's what this is about. And the thing that worries me, going back to my own experience about the fact that I didn't see any of these features, but it didn't really occur to me that this would ever be a problem. And that's just based on my background and my heritage and my personality and my parents and all these things, right? We know that all these things matter. I worry sometimes that we're maybe not targeting the diversity that's more hidden and less easy to measure. Are we recruiting people from rural communities? Are we recruiting people who have been financially impoverished? And I don't know that there's a box for that. And are those individuals now being left behind in this push for diversity because we're picking what's maybe easy? And I don't want to say easy because, truth be told, I think those who carry very visible differences in skin color, particularly and gender, perhaps might have borne the brunt of some discriminatory practices because they are easy to identify. And so it goes both ways. If it's less easy to identify, maybe you're less discriminated against, but you're also not raised up perhaps as much. And so all these questions sort of, I think we still haven't answered. And I'm just really interested in hearing my colleagues and their views on that. And also hopefully the views of the trainees. I know this is a GME luncheon. I will tell you our resident cohort is even more diverse than the faculty numbers that I just mentioned. And I am proud that within the residency, we do have members of the LGBTQ community. And we're trying to work out, it's a work in progress, how we foster that and how we are inclusive without making one or two people be the standard bearers for it. We don't want to do that either. We don't want to put undue additional pressure on members of very small minoritized communities. I have someone whose parents were farm workers, very much subsistence living, and she's first generation college. And so that's clearly a minority. And so how do we both celebrate that and use that to encourage others? And very much for me, this is a learning journey. And so even though I'm a representative sometimes of diversity, I feel like this is an area I have to learn a lot on. And then the final point I wanted to make without kind of belaboring this too much and give my colleagues a chance to speak, and hopefully we'll have good discussion with the questions, is that now that I do have the fortunate opportunity to be in some leadership circles and on boards of surgical societies across the country, I will tell you that the viewpoint I probably bring to that table most that isn't there if I wasn't there is the viewpoint of rural America and the surgical practice there. I cannot tell you how many places I've been where it feels like everyone is from Boston except me. And, I'm exaggerating, but only slightly, not very much. And it's so different how surgical practice is in the heartland versus in some of the coasts and in academic centers. And a small surgical practice in rural Texas is totally different. And I feel like that voice has to be heard as well. And it's very odd that someone who was born in Sri Lanka is representing that voice, but that's how it turns out. And so I really would encourage us as we start on this, and great kudos to you, Dr. Dent, and to Southwest Surgical for making this the topic of the luncheon. I would definitely encourage us to remember all these aspects of diversity as we go on. So I will turn it back to you, and I look forward to more discussion.
Awesome, Sharmila. Thank you very, very much. And yeah, I've got some questions for you at the end as a high-ranking leader in American surgery and some of your thoughts. We'll turn it over next to Dr. Mike Cornet.
Good morning. So at first, I thought when Dr. Dent asked me to participate in this, he was a little bit vague in his question, and I guess I'm understanding now that was more like when you ask an open-ended question. Sometimes you get much more a richer answer than you would have gotten by asking a very direct question. He said, just talk about you, just talk about your journey, as it were. But I did, as Dr. Tisaneki did make some comments about my journey, and also just some comments about this topic, and also again to point out how notable and how noteworthy it is that this is even a GME luncheon topic. So I would say most of us on this panel came up in a time where rather than talking about sort of diversity and inclusion, we talked about things like affirmative action. And, you know, the merits of affirmative action were debated, you know, the pros and cons and things like that. But it's much harder to argue with talking about diversity, inclusion, and representation. And so really we're here now as a result of very much a paradigm shift in how we think about diversity and how we think about inclusion. It's really the diversity inclusion is really I would say the next step beyond you know, trying to right some wrong as affirmative action tried to do, and rather to a place where ensuring that that it's a given that everybody has a place and that everybody has a seat at the table. And it's also a shift in not just those of underrepresented or minority backgrounds understanding it. It's also a shift in understanding of leadership to recognize these ideas that, again, as Sharmila just described, a lot of times it's preaching to the choir. It's like we never thought that we didn't have a place, but not everyone in the room did. And there's really been a shift, certainly in my lifetime and a career to understanding that. There's also been, or it's my observation anyway, there's really been a shift from what we used to call sensitivity training to really an understanding of intrinsic bias and understanding that that's part of both our how we see the world and make decisions as individuals, and also what's you know, part of the systemic bias as well. And rather than trying to eliminate those biases, to recognize that they are present in every decision and to start to weigh the impact of those decisions rather than to try to ignore them and speak around them. So some of the consequences of that bias are that women and minorities in surgery and in all professions are less likely to be mentored. They're less likely, they typically may not be offered the same salary. We know that they're not offered the same salary, and by extension make less. They tend to be more likely seen as an outsider, and sometimes not necessarily treated as being on board because they do have a different background and a different perspective. I think it's important for those in leadership positions to understand that when it comes to being a quote unquote outsider, that not everyone will have necessarily the same resources, not necessarily talking about monetary resources as we often think of, but really more resources as less community, less role models, less understanding of an individual's mission. Whereas those who are sort of the traditional academics, it may be obvious. Oh well, you finish your residency, you get an academic appointment, and you become an academician. Whereas other viewpoints and other backgrounds might decide, well, my mission is to go back to my community and to be a physician and to care for my community, to be a mentor in my community, and that can be a very different viewpoint. I do want to talk about my background, my journey a little bit. I went to medical school, Eastern Virginia Medical School. I grew up in Virginia Beach in Tidewater, Virginia. You know, at that time, I knew that I wanted to go to medical school, but for me and in my family, it wasn't, that wasn't a strange thing. My grandfather was a physician. He died before I was born. I never met him. But just the fact that he had been able to achieve that made it much easier for me to imagine. It's not, you know, beyond my conception. It's just, well, that's what we do. It's no big deal. That's an example of what representation does. It takes things from being beyond your conception to, well, that's just what we do. It's no big deal. And even in high school, I was aware of such figures as L.D. Britt, who was the chair of surgery at Eastern Virginia Medical School then and still is now. And so just having those sorts of figures and people in my orbit, if you will, gave me again the feeling that it's not beyond conception. So I'll sort of wrap things up and summarize. I think that there are some important paradigm shifts that lead us to this luncheon and to this being a topic, and from affirmative action to really talking about diversity, inclusion, representation, and talking about why all of those things matter to everybody, not just preaching in the choir. And I think when I sort of take all that in and personalize that, for me in my position, I really try to be the mentor, the figure that wasn't necessarily there when I was coming up. I had a lot of great mentors, but very few that looked just like me with my particular background. And so that's what I try to be. So I'll wrap up my comments and thank Dr. Dent again, and appreciate your attention. Thank you.
Thank you, Dr. Cornet. Now I'll ask Dr. Moore to come to the podium.
So I just want to start by thanking all of you for being here and participating in this, I think, really important conversation. I think I have a pretty amazing story when it comes to the experience that I have had as a gay female surgeon. I think, the process of coming out and letting people know who you are is something that is really important, but it's not always easy for people. I grew up in Texas with a very conservative family that wasn't necessarily embracing of my lifestyle. And so when I went to medical school, I assumed that everybody else had that same opinion of my family. And I think that was the first lesson that I really learned in my journey, was don't assume that people are not going to accept you. Just be who you are and let people come to you as they are. So when I left Texas and went to Chicago to do my surgery training, I encountered an entirely different group of people who were very open and very supportive. And so that really was my introduction to being in a world where it didn't matter that I was gay or that I was female. It just mattered that I was a really good surgeon and that I did my work and I trained hard and I became successful in my career path. One of the things, though, that I think is really important as someone who is now a little bit more senior in my career is to put myself out there and be available to mentor people and let them know that, there are struggles you're going to encounter and there are things along the way that you're going to encounter that are unique because you're a woman or unique because you're gay. And so I think, having a panel like this and identifying people within our surgical community that you can reach out to is really important. And along those same lines, I've had amazing mentorship. So, people like Fred Moore and Chris Kokenauer and Rosemary Kozar, who have really helped me along the way and supported me and promoted me in my career. And I think that's really been the difference for me in terms of, not having a hard time, not having a lot of discrimination that I faced. It was really because I had amazing mentorship and people that guided me along the way. That being said, there certainly have been times and stories I could tell you about things that I think shouldn't have happened. And I think how you handle those is important. But being true to yourself and really relying on your friends and your support network when you encounter those problems, I think is really important. Again, huge shout out and thank you to the people that have mentored me and got me where I am today. And if I can offer any sort of help or mentorship to anyone in this room, that's what I'm here to do. So with that, thank you, Dr. Dent, for the invitation to speak.
Thank you, Dr. Moore. And now we'll hear from Dr. Mangrum.
All right, so thank you, Dr. Dent, for inviting me. And thank you for all the previous remarks. Happy to be here, here in Hawaii. It's kind of interesting because, and I know I talk louder than everybody, they probably could take the microphone completely away, but I'm going to talk my normal self loudly. All right, so when they said a surgery, a place for there's a place for everyone. So of course, I'm learning how to say no, but usually when you ask me to do something, I'm going to say yes. So they asked me would I give this talk, and I just said, just say yes, and we'll figure it out. So then as we got about a month away from the meeting, I'm like, what is this place for everyone talk that I'm doing? And I asked my helper, who's really my boss, to help me. And she says, oh, they don't even want you to make slides. They want you to just stand up and talk. I'm like, ooh, that's probably not gonna be the best thing for me to do, just stand up and talk. I said, but double check. And so I don't know if you got an email or somebody got an email, but they said, no, well, we're sure. You just gonna stand up there and talk about a place for everyone. I said, well, surgery is not a place for everyone. There are some people who should not be a surgeon. I wouldn't let them come near me with a 10-foot pole. I said, so I'm gonna have to understand this a little bit better about surgery being a place for everyone. And then I said, oh, it's a racial thing. Is that, maybe that's what I'm dealing with? I said, well, I can talk about that. That's not a problem for me at all. I mean, I look young, but I've been here for 20 something years. And I remember when there was no female locker room near the OR. I had to go way down the hall, and the boys were right there attached to the operating rooms, et cetera, et cetera. I didn't look at it in a bad way, and it may be my upbringing. I just looked at it as, you know, hey, I'm a female. I want to be a surgeon. I'm going to do my absolute best and see if I can make it in this world. And I think Dr. Dent put it the right way, because it was a good old boy club. Okay, this was nothing but, you know, white males. And I don't think the world is like that anymore. I think the world is so much better. It's just unbelievable to me to watch the world. I mean, you guys, we've all gone through the coronavirus, the George Floyd, the whole thing. And if you watch these young people today, they don't really see color like we saw color. They don't. And it's amazing. My son is in the audience. We just came back from the Dominican with 3 of his friends. He's black, one white. I don't even know what color the other one is. They don't see color like we see color. And I think it's a beautiful thing. I think the world is changing in a crazy, great, beautiful way. I will say, Dr. Dent said, I started a residency program, I guess it was back in 2013, and we just got approved now for 20 residents. We started with 10 residents a year. Now we're approved for 20 residents a year. And when we started the residency program, it was we started it as a DO program, and all of my partners are MDs. And they're like, well, Alicia, why are we doing this again? Tell me why we're doing this again. I said, well, it doesn't matter anyway, because by 2010 or 20 whatever, everybody's going to be AC GME. It won't matter if you're a DO or an MD. It just won't matter. And one of my residents, one of my chiefs is in the back, Ryan, and we take MDs and DOs. We don't care. We just take the best. We just take the best. And as much as I would love to say as a Black program director that I have a bunch of Black residents, I don't. Okay, I just take the best. I don't care what color you are, whether you're Chinese, you know, white, Black, it doesn't matter. And I think I may not see it all come to fruition in my lifetime because I'm 50, but I believe that maybe not even my son, but for sure his children will see that we're getting away from this whole racial thing. And, you know, whether you're Black, white, gay, straight, whatever you are, we just want the best people. And these young kids are so much smarter than us. Like I said, I watch my son, I watch his friends, I look at who he deals with. They don't see anything we see. So start noticing if you got anybody, 14 and under, they hang out with everybody. They don't care. And I love it. And I hope we continue to encourage them. I hope we continue to support them. I hope that we let them know that that's really good. And the profession of doctors, and I have a little bit of this in my talk that I'm giving, but we have chosen such a great profession. Once you get that degree that says MD, whether you go into whatever, psychiatry, OB-GYN, surgery, whatever, we can do so much. We can do science, we can do translational research, we can do whatever we want once we get this degree. So I really appreciate you guys for letting me come. And now, do not tell me not to make slides, because I can talk. I love to talk. I think it's my favorite thing is courage. I think that's one of our greatest. If you can just have courage to stand up and say the truth. It takes courage to say, I love you. It takes courage to say, let's get married. It takes courage to say, I'm going to medical school. Everything takes courage. But if we can all have courage to stand up and do what's right, it doesn't matter about the diversity or your skin or anything. We just go to work every day and try to do what's right and help people. So thank you for inviting me. And I appreciate the time to speak.
All right, well, I'm glad we have plenty of time for discussion. I'm going to open the discussion, but I welcome others to have questions. There are some microphones on the floor. But I'm going to push back a little on some of the things Dr. Mangrum said. Some of the things she said really resonated with me, which is raising kids in San Antonio. I remember comparing my youth to my kids, bringing kids home, and it was rare they brought home another white person. And I felt so good about that. I thought it was great that my kids, who are now 27 and 25, are colorblind. Mm-hmm. But after that, and that good feeling and thinking that we had come a long way since I was at that teenage age, I learned that there are fewer Black men in US medical schools today than there were in 1978. Even though there are about 50% more medical school positions than there were in 1978. And there are other metrics like the divisions between the wealthy and the poor and things like that that show that as a society, we've gone backwards in the last 40 years or so. And I'm going to misquote this, but it made me think of the words of Martin Luther King, where he said something to the effect of, this age won't be remembered for the bad deeds of the bad people. It will be remembered for the absence of the deeds of the good people. And I feel like for decades, the good people sat by and did nothing. And one of the reasons I'm interested in this topic is I don't want to 20 years from now look back and see that we did it for another 2 decades. So I'd love to have us, this group, surgery at large, medicine at large, push so that we're not in that same position 20 years from now. But what do we do other than the things that you folks have talked about? What metrics do we use? How do we achieve those goals?
Dan, may I say something? Sorry, to tag on to that. Thank you. So, I love what you said, because I kind of agree a little bit. It's that preaching to the choir thing, right? Sometimes in certain circles, in households that clearly have a commitment to treating everybody equally, regardless of background and color and everything else, I think we can feel good because in that little bubble that we live in right then, it's good. And I'll tell you that I've been incredibly blessed and fortunate that that's been, for the most part, my experience, honestly. I mean, when people talk to me about what challenges have you overcome, I have to rack my brains a little bit, because either I didn't notice them because I was so busy barreling through. I mean, that's one of the nice things about being an incredibly type A focused, challenge-driven surgeon, is you're just not noticing things. And I think that's true probably of everyone on this panel, by the way. But I do think they exist, and I'll give you an example. So about 2 or 3 years ago, I formalized a policy in our department. And the policy is this. It is that we will not accommodate patient requests for their surgeon or any of the staff members to be of any particular race, ethnicity, age, gender, anything, except, we have one exception, if they would prefer to have a same-sex staff in the room, because of a modesty reason, we do accommodate that. So if it is a woman and it's sort of a pelvic focused thing, then absolutely. And if that, you know, and if it's a man who only wants men in the room because it's a hernia and he's off, that's fine. But other than that, we don't allow discrimination against anyone, and that is a formal policy. And I think it just we did it because I felt it allowed a clear line in the sand, right? It said, this is the bar, we are not going to tolerate this. So we have that policy. And I'm very glad we did, because at the time people questioned, do we really need to say this? And I'm like, yeah, I think we do. So anyway, about probably 7, 8, 9 months ago, there was a patient who had a history of being a little difficult, and their operation was canceled because of insurance reasons, not us. But she came back to the clinic and was infuriated and livid that the operation was canceled. And the staff tried to explain, this isn't something we have control over. Insurance says you don't need it. And the surgeon in that case happened to be one of our Black surgeons. And she chose to basically lambast him. He wasn't there, fortunately, but basically called him names that clearly alluded to his ethnicity and his color. And she was dismissed from the clinic promptly, and that was that, because that was the line we had drawn. And this was not an emergency operation. There was nothing medical that was going to happen to her by this choice, and she was not altered or anything like that. But having that policy allowed the clear line for us to support that surgeon to say, we are not going to force you to have this interaction and discussion with this patient. We'll do it for you. You shouldn't be in that position. And that's why I think it matters, and that we have this conversation matters, is that if we set those boundaries of what we will and will not tolerate for people, then it doesn't happen that often, thank goodness. And I am very happy. And I agree a bit with both of you. I think in a lot of ways, things are getting better. But I think we still have to have the protections so that the people fighting the battles are not the people who have historically also been victimized, as has happened for so much of history.
That's a great point, Sharmila. Any questions from the audience? Because I've got questions all day, so I can do this, but all right.
Can I?
Yes.
I don't know if this microphone is on or if you can hear me. Can you hear me? Perfect. Okay. So since the statistic was specifically about Black men in surgery and in medical school, I wanted to respond to that. I think that it's really it's a million issues, but it's also kind of two issues. One is when you're talking about, when you're quoting, nationwide statistics, they're reflective of nationwide problems. And so what can you do as a chairman of surgery or as a program director in surgery to address nationwide problems? Well, not much, unless you are willing to kind of, get out in the streets and protest and vote and do all the things that move societies. So those nationwide statistics reflect those national problems. But at the level of the program, at the level of the department, absolutely looking at your applicants and recognizing that your residency doesn't have to look a certain way or be a certain way or have different viewpoints. That is something that can be done, but in terms of that statistic, you're not going to change that statistic, but the people that you do encounter, the people whose individual lives you can make an impact, you should make that impact. You can make that impact and you should make that impact.
Yes, Dr. Menger. Great point, Dr. Cornet.
Yeah, and just to sort of to tailgate onto what Dr. Cornet said, because the question was very specific, because we don't want to backslide, as you said. We don't want to backslide. We want to continue to move forward. And the question is always, how do we move forward, again, with the world, not just with Black men or Chinese women or, Iranians? How do we just move forward with people that want to be surgeons? And then how do we keep this open mind when you're interviewing them? And I think that's a little, because to me, if you get to an interview, we're all people, and people have this tendency, we use the word prejudice, that's the wrong word. We just prejudge. That's what we do. That's what the word means. We prejudge. I can see you walking in and my mind's going, oh, look at that. We prejudge. That's what we do. And so how do we not do that and let the world evolve? Like you said, it's not just who our kids play with. It's just how do we get that prejudice or that prejudgmental thing that's so heavily ingrained in our minds to not do that. Laura, you don't even know, you said something that really impacted me. You had the same mentor I had, Fred Moore. Fred Moore just took me under his wing and helped me grow and be a surgeon. And I think we have to do that with all people without prejudging them. If we see somebody who, but no matter the color of their skin, how do we bring them up? And then we won't go backwards. There's somebody for everything. People are made to be lawyers, doctors, preachers, cooks, cleaners, homemakers, whatever. That's what makes the world go round. It takes all kinds of people to make a world go round. We can't all be doctors. But when we do find somebody that we can bring up, and it may be little things like, don't let school be so important that your kid can't come to a meeting and see people. I'm not going to listen to, oh, you're going to miss a whole 2 weeks of school. No, I don't care about school. So this is school right here, and we just have to pull people kind of up and not go backwards. I don't think we're going to go backwards. There's only one Martin Luther King. There's only one Barack Obama. There's only one Kobe Bryant. We all can't be that. But I could use other names, and I could be talking about, what's my football guy's name who's won so many Super Bowls? He just gets on my nerves. What's his name?
Tom Brady.
Tom Brady. There's only one Tom Brady. I think he's amazing personally. I mean, we have to foster what it is and not, if we could just get this skin thing out of our way, I think we'll do fine.
I think that's great. I guess my question to that is, how do we know if we're making progress if we're not measuring some of our things? And a little bit to Dr. Moore, one of the metrics we can't measure, as I've looked at this in other organizations, is sexual preference. That's not listed. A lot of people now are actually listing race and gender and things like that, but sexual preference is not a metric that anybody can really see or measure. How do we make progress on something we can't measure?
Well, that's a great question, and I don't have a good answer, but I think it starts with, being aware and, acknowledging people for who they are. And so I think, the difference between, say, Laura Moore in medical school was, if I went to, a work function or something, I would go by myself. I wouldn't take my significant other. Fast forward to 20 years, and that's completely different. And I think part of it is people being open and being out there, and those of us that maybe are in those minority groups, bringing our significant others to recruitment dinners and holiday parties and work meetings and identifying that, and it gives everyone an opportunity to maybe see something they haven't seen before. Maybe not everybody knows someone who's gay or someone who's, in a relationship where they're, long-term significant other that's same sex. And if you've never seen that before, maybe you're not comfortable with it. So part of it is on us to be out there and not hide from it and not, be afraid to talk about it. But as far as a metric, I mean, I get it. It's tough. It's hard to, ask that question. I know in our university, we do, every so often throughout the year, there are diversity surveys that the university sends out that are anonymous that you can answer. And that is one of the questions. You don't have to answer it, but you can answer it. And so I think that's a start to sort of identify the diversity within the population of an academic center. And so I think we're doing that certainly at UT in Houston, and I don't know if other institutions are, but it's de-identified information, but it's a question that gets asked.
Yeah, we're doing the same in San Antonio, but right now we don't have good numbers.
Right.
And most organizations also don't have numbers on that. And we're trying to get, the board of directors of various surgical organizations to have more diversity. And that's the one metric we don't have data going backwards on to compare to. Question for each panelist. as you came through from elementary school to the completion of your surgical training, barriers along the way, where do you think the biggest barriers were relative to you not being the majority, if you will?
I guess I'll go first since I'm closest to the side. I think it's been alluded to. I can't remember which panelist sort of said so, but it's been alluded to when you talk about barriers. There are definitely barriers in terms of if you want to go to a specific place and the place where you want to go is the decision makers there are not going to see you as being able to do the job because of who you are. Well, maybe you should reconsider your choice, but at the same time, those are clear barriers. But when you ask what barriers, I mean, I would kind of say none, which sounds like a weird answer. But at the same time, if the scores that you need to get in are these scores, well, I will meet and exceed those. If the performance level that is the expectation to advance, I will meet and exceed that. If I need these grades and these, SAT scores to get into college, I will do those things. So for the determined, there are clearly barriers. I mean, obviously we're all here. And so the barriers are really personal barriers. They are much less physical barriers, and they're much more personal barriers, feeling like you belong, as Laura alluded to, being able to bring your significant other, feeling like you're part of the group. Those are all, sort of internal barriers, which are to me are much more so than any real physical barriers. Most of the physical barriers, most of the systemic barriers and quotas and things are not in the system anymore. It's those personal feelings of being involved, finding mentors. It can be harder to find mentors. It can be harder to find people to bring you along the way. So I think most of the systemic barriers, I don't feel like I encountered. I feel like there are much more personal barriers to feeling like you can belong and achieve.
Okay. Dr. Disanaki, we haven't heard from you in a while. What are your thoughts on this?
It's an interesting question. I'm probably going to give you an answer you didn't expect. My biggest barriers and obstacles in my personal, and actually a lot of people don't know this, were probably from the ages of 3 to 14, and I'll explain why. So I'm Sri Lankan. My parents left Sri Lanka for Zambia. That was at the time developing. They were both accountants. My father was going to lead the utility company, so went abroad for a better life, as many people did, especially from South Asia. And so my earliest memory is the jet plane engines, actually at 2.5. And so I was myopic, severely myopic, but I felt that was a failure. So I took great pains to hide it. I would walk past the eye chart and memorize it so I would pass the exam. So I was 8 years old before someone finally figured out I needed glasses, and I was -8 by that point. So I kind of went through my early childhood blind, essentially. I was in Zambia, and then I went to Antigua, where, my mom would insist on putting coconut oil in my frizzy hair, so I smelled weird and different. And I was a new kid in class 7 times before I was 11 years old. And then I went to Sri Lanka, where I had the West Indian accent, and that wasn't great either, and couldn't really speak the language. So I will tell you that once you've gone through those childhood experiences, everything else is a piece of cake. Adults are remarkably well behaved. And so my trial by fire was that once you've learned to adapt to new cultures and learned how to survive and then succeed as a child, really adulthood becomes very easy. Now, I'm not recommending torturing your children as a way to make them succeed as adults, but I think it's important to realize we are all a product of our upbringings. And I think one reason why it literally never once crossed my mind that anything about me would be a barrier to being a surgeon is because that was a very old story that I'd already figured out as a young child. And I think that is one reason why I was quite oblivious to it. But those were the barriers. And truthfully, you know, it worked out for me, but it could have gone the other way. I mean, I think that alienation and being new and being culturally different and being quite blind for most of it could have turned out quite badly. And I'm very fortunate that it didn't. And I had supportive parents who were doing their best. But, you know, I share this story also because I think another thing is none of us know what the struggles are of the people we've been going through and where they're coming from. And I think that does have such an impact of how we cope with the struggles we face now.
Awesome. Thank you. Dr. Moore and Dr. Mangum, about 30 seconds each. Where were your obstacles?
I would just echo those comments. I think, you know, most of my obstacles, I think, were in finding places where I fit in. And it, I was very fortunate. You can always find a place to fit in, but I think, you know, the number of places that were open to me where I felt like I could go and be happy and be accepted was limited. For example, when I was applying for residency spots, but you know, you self-select your people in places where you know that you're going to be open and welcome and, you know, part of the family, if you will. And so I think that's the main limitation or barrier that I've seen is it did limit somewhat the options of where I could go and be accepted.
Dr. Mangum, the final word.
Yeah, and I would just say that when it comes to barriers, I think because I'm older than these two to my right here, just being a female was a barrier. Like I said, it was just down. It's not a barrier. We know that there's more females in medical school, et cetera, et cetera. But I would really just echo what you said, Mike, Dr. Cornet. You know, the barriers are pretty much gone, in my opinion. You need this test score. You need these grades, you need this MCAT score, and you can get in. I don't think it's as big of a barrier. I think there still are some, like I said, some things that, you know, we're going through, but I think those barriers, if you do the right thing and you stay determined and you have, you know, what do I need to get into this residency? Okay, I'm gonna make that. I think you're gonna get in. I do.
All right. Well, I'd like to thank all of our panelists for sharing their stories and their heartfelt thoughts on this, and appreciate the audience for your attention. Thank you very much.
Thank you.
Thanks.